Let's talk about something that is kind of hard to ignore at this point, and that is that at least yesterday, just at UAB, that's only one hospital, there were 92 coronavirus patients that were hospitalized at UAB. That is among obviously others across the state, but just at your hospital, 92. That's a pretty high number. We were seeing several weeks ago, we were seeing in the 50s and the 60s. This 92 is a large number. What are we worried about there? Is that number a frightening concern to y'all, or did you expect it to get to 92?
Yes, kind of some of both. So we had a very early spike as COVID started having community transmission locally. And then, as everyone remembers, there was a pretty robust response to trying to figure out how best to kind of mitigate the local transmission. And frankly, if anything, I was surprised at how effective it was, that our cases really did respond pretty quickly. And we had this kind of steady trickle of cases coming into the hospital. And then, as everyone also knows, the conversation started evolving a few weeks back, particularly leading into Memorial Day. And I feel like there's pretty consistent messaging that, at least from the expert side of things, that we would anticipate that would lead to an increase in cases. And that has kind of been borne out by our experience. We have gone, as you mentioned, from in the neighborhood of 50 inpatients to now where we're at 90. Some of that number is long-term residers that are having really severe manifestations and they stay in the hospital a long time, but there's been a clear uptick in daily turnover, both coming in and then coming out for theirs that are kind of more manageable cases. And then the challenge really becomes is that for every 20 cases that we have come in the acute setting, a subset of those have more severe progression and they have a longer course of disease. And so as we're taking in 10 to 15 a day, a lot of those are doing okay, they're getting better, but every time a couple of those have worse progressions of disease and they just kind of stay. And so we're having this ever expanding cohort of very sick people that take a long time to recover. And we have finite resources in our ability to kind of take care of those folks. Regionally, this is not unique. This is what's happening all across the Southeast and some other areas across the country that have had kind of this native stable progression in number of cases. And inevitably that leads to limitations as far as our ability to kind of provide the care that we would otherwise like to do. That has been mentioned specifically in limitations in access to certain medications, which we can talk about some of those. The one that seems to be the most kind of on people's minds is thinking about mechanical ventilators, which is, our kind of last resort intervention for those that have really severe respiratory failure. And we do not have the capacity to keep expanding that access. And right now our trajectory suggests that we will run into limitations for our ability to take care of people how we otherwise normally would.
So that's saying if we continue operating in the way we are and have people that don't take things as seriously or follow precautions, then it could lead us down an even worse road than we are now.
Yeah, this isn't a spike. Like a spike implies that there was something that changed that is now changed back and we would expect it to go away. This has been a consistent trend, and frankly, it was predicted too. And so these numbers aren't where we are. They're actually lagging behind because of the exposures that have happened in the last week. There's a 2 to 3 week lag in those that are in the hospital. So where our numbers are today are a major concern, but where our numbers are inevitably headed based upon our prior experience, what we understand about this disease makes it even a greater challenge. And so constantly trying to predict where we are. And then also there seems to be this expectation that, well, it's going to die down, but that's not how we are thinking about this. And this is relatively early still in the phase of things. The data out there is limited, but kind of the seroprevalence or best guess as far as the number of people that have actually had COVID that are unlikely to get it again in the near term is still in the neighborhood of probably 10%, which suggests that, we are 1/10 of the way through this, or maybe 1/5 if you want to be really generous, which still, again, that projects us out months down the road of this.
Right. Now, just looking through some of y'all's questions, we're going to get to Ginger. We're going to talk about schools in just a second. We have several questions already. I've got written down about that. A couple of people that are asking about, well, we're not wearing masks. We are not together. We're actually several miles apart. Technology has brought us together here. Yep. He's got his. I've got mine in this messy room somewhere.
I probably have like a little indentation because mine was on coming from the hospital back over to my office. But yeah, I have a 6 feet spacing with me and the wall, so I promise I'm good.
Right. And y'all, I am by myself. I got 3 dogs somewhere around here, but not with me, not in 6 feet. So just to go ahead and tell y'all that it is a split screen here. So we talk about those numbers. Something I want to address before we get into schools, and Mara brought this up here in the comments, is the death rate here in Alabama. Now, we've heard a lot of people in the community saying, oh, well, our death rate is not that bad. Our death rate for several days was trending downward. Should we really be that worried? Is that data that should make us feel comfort in that the death rate is lower, or is that something that shouldn't be our security blanket at this point?
Yeah, it's all a matter of perspective. The death rate in some of the earlier really fulminant outbreaks in Europe and New York were a product of limited understanding of the disease, severity of disease, number of cases, but then also limitation of resources. And fortunately, we didn't have this tremendous early spike, because by the time we kind of had full community transmission here, we had some testing to be able to keep some tabs on it. I don't think even with kind of modest social distancing that we should be able to avoid some of the tremendous spike in cases that we saw in some regions. That said, the death rate, it's a matter of perspective. Like, there's a lot of disease that happens short of death. And I am very comfortable in saying no one watching this wants to go through some of the tremendous challenges that some of our patients have had. And then also, the death rate lags behind the number of cases. So our mortality manifests weeks out from when they present. And so this kind of significant uptrend we've seen over the past couple of weeks, I wouldn't really fully be able to appreciate the amount of mortality that we would associate with that for another couple of weeks down the road. And again, projecting cases today based on lack of intervention, we would expect to have more cases in 2 weeks, because that's how long it takes for that to trend. And mortality probably another 2 weeks after that. So we kind of have a month to fully appreciate how many people are going to succumb to this. And the death rate across the country and locally it's really astounding. I mean, over 100,000 people appear to succumb to this. It's terrifying. So it's a big deal. And it's hard to grasp that, because it's still happening beyond like what people see. It's not in their family. In most cases, there may be a couple cases in their community, and the number of cases that people see, the vast majority of those are self-limited disease. So most people do get better. They may feel pretty miserable and they may have some complications, but most people don't die. But it's just too easy to kind of sweep that under the rug for every 1 or 2 people you may know. That's projecting to dozens and tens of hundreds and whatever scale we're talking about that are having much more severe presentations of it.
Well, let's go ahead. Let's jump into schools. I know Ginger has asked, what do you think about in-person schooling? And we had a similar question from Twitter, and this was from Mark. And he was saying, what about if in-person school, if those schools don't require temperature checks, if they don't require masks or things like that, what could we be looking at in the fall with in-person school?
So this is such a tough topic, and it's interesting to think about how much different the kind of social response would have been to this disease if it would have skewed like most of our infectious diseases, where it really preys on the young and the old. For a variety of reasons that we don't fully grasp, children do have a lower frequency of contracting the disease, have a lower frequency of having symptoms, and have a lower frequency of really severe outcomes. So that is completely skewed how everyone approaches this. And the way it's been talked about, it's like, well, grandma or the nursing home was one thing, but kids are fine. And in reality, it's not that simple. And there still are kids and young people that have more severe presentations, and that is skewed more towards kiddos that might be susceptible because of other medical problems as well. But that's kind of a separate issue from the question, which is, how the heck do we deal with schools going forward? It's also not a simple conversation, in that any legitimate conversation about schools needs to acknowledge the urgency of getting kiddos to school. Like, society benefits from having kids at school, from having access to the nutrition, from having access to the social interaction, from having access to the education. We are going to have kiddos that don't meet their full potential because they have been not having access to teachers and their classmates and that environment. So we have to acknowledge that, which makes everything kind of wishy-washy as we go through it. Another concern that I have in thinking about schools is that some people are working under the assumption that there will be no cases either amongst staff or kids, and that strikes me as pretty unreasonable. And then how each school district decides to respond to the cases that are all but inevitable given our rate of current community infections right now seems pretty impractical. So getting into the specifics, it is very difficult to live right now, particularly in our region, with a 0% risk of exposure to COVID. And really, that's not how I function or how I recommend we function. It's more of a matter of risk mitigation, things that we can do that decrease the high risk things. So that's why restaurants and gyms and large gatherings are easy targets, because that makes sense. If you have one person that get exposed, that's one thing. But if you have 100 people simultaneously get exposed, that's a huge issue. So schools seem to be responding as best they can to trying to do some risk mitigation of, and those particularly older kids that can handle it, masking makes some sense. In trying to have optimizing spacing as best they can, and trying to really educate families, kiddos, and parents for those that may have symptoms, that it's really urgent that they don't come to school, knowing the challenges that presents to each individual family. That's an easy thing to say, and yet when there's not social support to kind of make that possible, that's a big ask for families. There are going to be cases, and the vast majority of kiddos that have cases are going to be mild, but that still bears a cost for the community and society at large, because those cases then have the risk of transmitting to others.
So are you saying is it worth it? Is going back to school worth it for those cases that will inevitably come?
I have opinions. Whether or not my opinion is really the one that matters is probably a separate issue. The American Society of Pediatrics has argued that it does make sense to proceed, and I tend to lean that direction. Again, what society needs from school, the benefits of school, probably outweigh, particularly in light of how much community transmission we have right now. But we also need to be practical about trying to make sure we don't allow that to be another driving factor of transmission, and then being responsible about how we deal with it.
Pivoting away from schools for a second, I see this question from Dylan, and I think it's really interesting because I got a similar one from Twitter. But Dylan says, I'm an essential worker. I've been everywhere, all over. Is my immune system strong, and can I depend on that for being free of COVID at the moment? And several similar people said on Twitter, several similar questions, I should say, on Twitter said, if I've been going out and acting like everything is normal and I haven't gotten it yet, then what's the problem?
Yeah. So, I've been in the room with well over 50 COVID patients, probably over 100 at this point. We've done research on my samples as controls and as also as kind of seroprevalence studies, and I haven't contracted COVID yet. That's not likely to be a function of my immune system. It's more likely that I've been able to limit my kind of inoculum, so how much virus I was given exposed to. Because I was ended up being exposed early on before we had routine testing. There's people in the hospital, so I know that I've encountered virus, and I've no doubt encountered small amounts of virus, even when taking reasonable precautions with PPE as best I can. That gives me no confidence that I should just assume that projects forward. Like that's not how this works. So your limited exposure, or the good fortune of not having a high risk exposure, or even if you've had a high risk exposure and didn't contract at that point, should not make you feel like, oh, well, that excludes my risk going forward. Even if you're young and healthy and your likelihood of having severe disease is low, I still argue you have a commitment to your neighbors and your loved ones and your family and those that you encounter to try to limit your risk for expanding the number of transmissions that we would have for any given person. And again, I'm not advocating for a 0% risk tolerance such that we all live in an isolated bubble, but the risk mitigation is key. So avoiding higher risks and taking reasonable precautions is where we really need to be pushing for as a community.
So we talk about that when you're saying, look, we're not expecting a risk-free environment. We are trying to just limit our risk. Let's talk about that. And what kind of activities are low risk? It is summertime. Everybody hates that this pandemic has really erupted in summer, where most people want to be socializing, want to be out and about, and kids are out of school. It would be, arguably, this would be a little bit easier if it was in the dead of winter. But how dangerous are activities, going to the beach, going to a community pool, doing some of the more quote normal activities for the summer? How is that increasing or not increasing your risk?
All right, so those are key questions. One thing that we have a pretty good handle on at this point is that even modest social distancing efforts when you're outdoors is pretty darn successful at limiting transmission events. So with kind of unlimited ventilation that you have outdoors, perhaps even some of the environmental exposure of virus to sunlight or whatever, it's just harder to have a sufficient inoculum to have a transmission event. So if you're taking even reasonable precautions of social distancing, so trying to avoid other personal bubbles, I feel that most outdoor activities are reasonable. That goes out the window if you have people touching each other and coming in close contact with lots of other people. And some of the pictures we've seen coming from the beach where people are having parties, like that's not having any consideration for social distancing, and I would not advocate for that at all. What we do know is that indoor exposures are significantly problematic, particularly those that involve increased kind of respiration. So we have case reports of dozens of people getting infected by a choir exposure. So choirs practicing and vocalizing, that's a high risk thing. Gyms where people are breathing heavy, they're more apt to be able to spread viral particles. Restaurants where you have multiple people having sustained conversations, you have limited ventilation, those are high risk exposures. And obviously things like movie theaters or concerts where you put a high density of people in close contact, those are particularly problematic. So outdoor activities with even reasonable precautions are generally quite safe, although that's a challenge in Alabama when it's 174 degrees outside and 98% humidity. But then indoor activities, especially with larger gatherings, are really hugely problematic if you're not very vigilant about how to do that.
So if, say, me and my husband or me and, one of my girlfriends, we want to go on the beach, lay on the beach and be reasonably 6 or more feet apart from other parties, is that a low risk activity?
It's hard to define low risk, but as far as kind of our risk mitigation discussion, that's pretty reasonable. The challenge I see with traveling and doing the types of outings is that you have to get from point A to point B, and that when you're not at home and have access to your own space, that means your lodging situation, you might be putting essential workers at higher risk. There's restaurants, there's getting gas, there's some of these other things that are more logistically challenging. That said, like, the world doesn't need to shut down either. I mean, there's a balance here, and I think we need to acknowledge that balance. And that type of activity is certainly more favorable than going to an amusement park or something else where you're expecting there to be crowds.
So crowd-free is still something that you and other medical professionals are advocating. There are other questions that we've gotten regarding masks. We have all heard the national and the statewide conversation around masks. There's a lot of areas across Alabama that do have mask ordinances, including in Jefferson County, where you and I are located right now. There were talks even that the governor, I don't have the quote in front of me, but it was something along the lines of y'all wear a mask. And she said that she, at the time at least, was not implementing a statewide mask order because she said it would be nearly impossible to enforce. Now, saying that, there are people that believe, or rather don't believe, that wearing a mask is helping them. They cite earlier discussions in the pandemic. And also there are people that do believe and do wonder about breathing in their own breath back from that mask. And we've heard just a lot of different opinions. So what is your thought about masks?
All right, well, there's good news that we have some evidence to back this up too. So it's not just me pontificating. So we can kind of walk through that. And full disclosure, very early on, I and others kind of in this expert role did not strongly advocate for masks because there are limitations to what a mask can do to protect me. I wear this thing in the hospital, and when I go out, not for me. Virus still makes it through this fabric, although less. And then this fits in such a way that I breathe around it. But I'm doing that intentionally because the mask really primarily isn't for me, it's for those around me. And I know that I'm relatively high risk because of what I do. And so I'm pretty darn stringent about making sure that I'm limiting my ability to transmit to others. Even knowing that I don't have symptoms and I'm taking every reasonable precaution, I'm wearing this for you if we're walking down the street together or going to the grocery store. So there is data to suggest that, surgical masks, cloth masks have limited utility as far as preventing your ability to get infected. And also we have data that people end up futzing around with their masks, and then they end up inoculating themselves with some of the fomites that we don't want to do. So masks on their own have limited benefit to each individual, but there's also modeling that suggests masks are tremendously effective at decreasing the community transmission rate if they're worn with any regularity in some of these higher risk exposures. So the mask guidelines are coming down not because we know that they're tremendously effective for each individual. What the mask recommendations are for is such that we have decreased overall transmission frequency. You can find plenty of videos on YouTube that just show what the ventilation pattern looks like with a mask when it dampens down your respiration. So instead of disseminating small amounts of viral particles all throughout that get passed around, they're all kind of contained in a very finite area. And that's what we're going for. The Facebook memes about like somehow your carbon dioxide can't go through this is utterly and totally preposterous, and lives in the void of any physics or biology. So it is a non-issue. They can be somewhat uncomfortable, but there's a variety of different ways to accomplish that goal of dampening how far your breath goes. And so I would encourage someone who doesn't like this to try something that's cloth, or someone to try one of these little neck gaiters, something that works for them. I don't have strong feelings about exactly what the mask is. And again, my primary goal is not to have something that is all but like ironclad in preventing virus getting to me. What I'm trying to do is at a community level, dampen our ability to transmit. It's unfortunate, but I guess not that surprising that it has a political connotation to it, because it is such a visual thing when you're participating in society and choosing to wear a mask or not. But again, our point is not to make a political or expert opinion. It's just to protect your neighbors and your community as best we can. It's not a perfect solution, but it's a low bar to accomplish a significant benefit when we think from a larger perspective across dozens and hundreds of people in our communities and cities and region.
It's again one of those maybe it's better than nothing situation. And again, like you said, that the thought is not necessarily that it protects you, it's that it protects me or it protects the other people you're around. Again, we are not in the same room, y'all, but it protects the people that you are around.
Yeah, the modeling is pretty profound. So, and I don't want to understate, like, masking looks to make a huge difference if a critical mass of people participate. That benefit dissipates rather quickly if there's a lot of people that don't, particularly in the higher risk things. Again, not zero risk, not tremendously high risk, but the things to try to, like, again, going out, getting groceries, doing basic functions, like masks have benefit for that. And again, it's less for the individual, more for the group. And that's where these guidelines are coming from.
Let's talk about asymptomatic people who have been, and again, for maybe people who are not familiar, that's people who have tested positive for the virus, but they do not feel its effects. Can those people spread the virus?
Yeah, so there's a couple different ways to think about it. One is pre-symptomatic and another is asymptomatic. So a lot of our early data was skewed because we had a cross section of people that did or did not have symptoms, and some of them were positive. And then we were trying to sort out who was able to shed virus, but some of those people that were asymptomatic at that time then later developed symptoms. So there's pre-symptomatic and asymptomatic. Pre-symptomatic, unlike the degree to which influenza does this, pre-symptomatic in COVID clearly can shed and transmit virus, which is a public health nightmare. And one of the challenges to this response has been that waiting and being aggressive to manage people that have symptoms does not provide sufficient kind of protection to protect communities. So we're stuck having to deal with everyone. And particularly when we have transmission rates in the community right now, that to the degree that we do, I function like that. Anyone that I don't know in my social circle is considered high risk, or I just have to function as though they are shedding COVID, because it is not uncommon right now, given how many cases we have. And we just have to function in that setting, because even if they haven't had a cough or haven't had fever, they still can be shedding virus. For asymptomatic, I think we're going to get more robust data from kind of prospective studies that here at UAB we're participating in, but that are happening globally. But there is viremia, there is viral shedding. That is something that can totally happen. The degree to which it happens versus someone who's coughing is a little bit less clear, and I don't want to overstate what we do and don't know for sure. But that is certainly a component to kind of how this disease process works, which is a huge pain in our butts, but it is the reality of it.
So pre-symptomatic, yes. Asymptomatic, jury is still out on that one.
I mean, it's yes. I feel comfortable saying it's likely that it's not going to be to the degree which someone that does ultimately develop symptoms. But it's hard for me to give a more nuanced or definitive answer than that right now, just because I end up projecting on data that we don't have fully available. But asymptomatic people do have viremia, which means they almost certainly can transmit virus to some degree.
Let's talk about contact versus respiratory droplets.
Yeah.
Now, we know that the reason we're staying 6 feet apart from each other, that we're wearing these masks, is to prevent those droplets from getting in the air or to be far enough away where those droplets don't make it to you. But what about contact? Is this something that I know in the very beginning of this pandemic in March, we were extremely cautious about wiping down our groceries, wiping down the gas pump and our door handles and everything else? Are we still concerned, or does data still show that the virus is able to be passed along through contact of surfaces?
All right, so I don't want to overstate what I do know, or I don't know what we do or don't have data on. It is certainly possible that at least to some degree we can have fomite transmission, meaning that if you have a high concentration of virus present on a given surface, that we know you can retrieve viable virus from those surfaces, which means you could then inoculate yourself. It certainly appears that that is not the primary mechanism of transmission. And again, going back to masks and social distancing, because that's what we worry about, is being exposed to kind of aerosolized small particles. So then it goes back to kind of our primary thesis in the beginning here, which is taking reasonable practices for risk mitigation. So as opposed to never touching anything again, robust hand hygiene, washing your hands when it's reasonable, trying not to touch anything more than is necessary when you're out in public spaces, acknowledging that there is some risk for contact exposure, but that it's probably less than being near others that could be shedding virus. I don't take my kids out into public space. They don't go to stores because I cannot keep their little hands off anything, despite no matter how many times I tell them. And so we just have to limit our kind of nuclear family exposure by keeping them out of those high risk places. Because I don't want to transmit to others, and I don't want them bringing it back in, but that could then put my patients at higher risk as well. That said, carrying around an ethanol bottle and spraying every single thing that you come near is not feasible. And so we have to function in that reality of trying to limit high risk.
Interesting. We got a couple of questions. I know that the doctor's busy. I'm going to give him a couple more questions, but some of these go back to schools. I know that's not surprising. One that I thought was really interesting, and I'm trying to find it. I believe it was Joyce that asked this, and she said, when you made an earlier comment about choir and an outbreak that was attached to a choir practice, what about we go back to school? Should choir and band, those practices and those classes, how should we handle those?
I looked at data yesterday on wind instruments. And because of the nature of the wind instrument, it's not as much of an aerosolizing thing as you might worry about.
Very interesting.
That said, it's not like robust data that we can really apply at a broad level. Again, I think it goes back to the underlying thing of trying to do what is reasonable to avoid higher risk. So I would probably not be enthusiastic about my kids standing 6 inches away on the kind of classic, middle school risers, all singing their hearts out for whatever dinosaur song they're being taught that month, because that seems pushing the envelope more than is really necessary. And again, being tremendously sensitive to the ability and urgent necessity of kids getting exposed to what kids need to get exposed to and those types of learning opportunities. I think that degree is probably unwise. Marching band in this wind instrument and outdoor exposure, that seems a lesser degree to me. But I don't claim to have really robust data to make a true risk assessment on that or not. But again, trying to take reasonable precautions is what I would emphasize.
What about something Whitney brings up, outdoor playgrounds and recess time?
Yeah. So again, outdoor activities overall, good. Kiddos sticking their fingers in their noses and their best friend's little eyeballs, less good. So then it's just trying to mitigate the risk there. So again, we have a few kiddos that I got 2 little boys that are very much in the handsy, grabby, fingers in the nose stage of life. And so we don't have them playing with large groups with any regularity, but we do let them run around and scream like the little monsters that they are with a kind of couple groups of kiddos that we know that there's some degree of risk with that, but we're able to limit the risk overall because we're not exposing them to a large number of unknowns. So play is good. Outside is better than the alternative. And so I think that's reasonable. Again, you're just trying to do what you can to take reasonable precautions.
And what about that equipment, the jungle gyms and the slides, things like that? Are those equipment things that need to be wiped down between kids? Is that even reasonable?
The latter, probably not in most cases. Again, if you have a kid that's wiping their nose and then grabbing a handlebar, like there's not a zero risk there. It's just hard to say. It appears that environment is not terribly conducive to making happy little virus. The virus would much rather sit on an indoor door handle than it would be on a hot metal surface being exposed to the sun. So the relative risk is probably low, but quantifying that in a definitive way is hard. And again, my take on that is that the risk is lower, and that makes it more of a practical activity than what others could do.
What about our teachers in school? Our older teachers, any or more at-risk teachers, staff, bus drivers, you name it. If we go back to school, and I say we, I'm not going back to school, but I say we as in children and even in college, what about those staff and employees? Will they be able to reasonably feel safe in an environment like that? Or what do you think about that?
Yeah, so I mean, there's so many different cogs of society that end up taking in a disproportionate risk. You know, our ER screening physicians and staff, they're getting exposed to people all the time that don't realize that they have potentially COVID symptoms, or that do but aren't taking optimal precautions, or that do everything they can but they have such a high amount of virus present that they're still putting healthcare workers at risk. So many of our essential workers that we rely on day to day for whether it be food preparation, waste removal, and everything in between, they're carrying more of this burden than others. Teachers certainly end up landing on that front line because their role really depends upon coordinating groups of people. Going back to the comments earlier, is that young children seem to have less burden of disease, less viremia, and less symptoms, which is favorable. But again, if you have 300 kiddos, the risk is still not negligible. School systems and staff are going to be really pressed to try to take as best reasonable precautions as they can. So spacing, masks as they're feasible, robust hand washing, those are kind of really your best avenues. If my wife was really high risk for underlying health comorbidities and would be expected to be in the setting of teaching lots of kids, that would be a really individual based decision, and it's really hard for me to give a definitive answer overall. Again, you want to take as reasonable and practical precautions as you can, and yet acknowledge what we can and can't control, that it's not a 0% risk, and really we shouldn't be able to, we can't put our schools or really any other facet of society on a 0% risk setting right now. What we need to do is limit community spread, invest in resources that we can do the contact tracing that we would really want to do, but that would require us to have transmission events that we can keep track of. We cannot track contact tracing for 1,100 people a day across the state. We need to be in a situation where we're identifying the handful of new cases and quickly identifying those that could be at risk. That's what we were advocating for a few months ago. And that's what we need to start trying to work back towards, so we can get to the point of keeping things in somewhat degree of check, and then allowing us to get further along with the vaccine development that we're doing and with the treatment interventions that are coming along.
It's kind of back to our choir topic. I thought this was interesting. Betty says she's the president of the Elementary Alabama Music Educators Association. And Betty, I'm sure love to hear about what y'all's plans are for the fall and for chorus, for band, all that kind of stuff. So that is interesting, Betty. We know that you are a very busy man, doctor. We appreciate all of your time today and answering our questions. And for all of these questions that we haven't gotten to, we will try to get the doctor back to get here and answer them for you. But we just appreciate you so much, doctor, and for your time.
Well, again, I appreciate this format too, because so much of this is challenging because there's unknowns and there's nuance to it, and it's not just a simple this is the way to do it. So there's all this middle ground, and being able to kind of talk through that, what we know, what we don't know, and try to give reasonable kind of guidelines, as opposed to this is how it has to be done and this is how it's going to work, because we just don't have that degree of certainty yet. So I appreciate you for taking the time to talk about it and giving me an opportunity to kind of weigh in and help folks out, hopefully.
Absolutely. Well, again, thank you, doctor. Thank you, everybody, for watching, and everybody, will see you tomorrow.
Thanks.